For Lincoln, RNs and CNAs, helping patients to test their glucose at home. How do people think about home testing? We'll talk about that. How can we help patients learn to test and engage in useful testing at home during a brief office visit? Well, first, I've heard this many times. A patient will say or will be thinking, I don't need to test because my sugar at home, because there is that 3-month test you all do in the office. And the professional can say something like, well, the A1C test is great to show the average of all sugars on all days at all times. But home testing gives immediate information and tells us exactly what to do to improve things. Self-monitoring is not well utilized because patients think often something like this. They are all high. I get depressed looking at those numbers. Why would I keep doing something that doesn't help, that makes me feel bad? If a patient does test, she might hand over the meter or paper record and only has looked at the results at the time the test was done. Instead of having done some thinking and the patient and healthcare professional looking at it together. Patients want to know, well, what's in it for me? Why am I doing this? Is it just to be evaluated or see that I'm bad? Well, quick review. We know that home testing can provide immediate glucose information to distinguish at different times of the day. We would like for it to be viewed by patients as an experiment, a lab in my kitchen, the goal of which is to discover how the body responds to a variety of factors. So there's 2 skill sets involved, operational and interpretation. Now, the American Association of Diabetes Educators website, which is diabeteseducator.org, patient resources under that tab, and then tip sheets and handouts, they make a couple of excellent points. You want to use the thinnest lancet possible, or that gets blood. Use the 3rd, 4th, and 5th fingers and rotate. Don't use the same one all the time. Prick the sides of the fingers, not the tips. And with the finger hanging down, use a press, release method if needed, but not excessive squeezing or milking, as that can change the result and, of course, cause some damage. And have the meter on the table with a strip in it and slide the butt of the finger slowly toward the strip. And in other words, not have everything sort of up in the air and have it be extremely awkward. And completely fill the small area on the test strip that's needed. So here we have, wash the hands vigorously in warm soapy water. Hang the hand down at the side, below the heart. And adjust the depth setting on the lancing device to allow for depth of puncture needed. And in obtaining an adequate sample of blood, use the smallest gauge lancet possible to get the amount of blood you need, and use that press-release repetition if needed, but avoid the milking or squeezing, certainly not squeezing. Well, you want to give the patient information. They will value what you say, and it will help them start and continue testing. Warm soapy water and dry thoroughly. This reduces discomfort. It's more accurate than with alcohol, and there's no infection. Now, granted, if your facility says you have to use alcohol, that's sort of another issue. But we do want to know, to help people to believe the directions are given that say this. And when you do use alcohol, if you use it, dry thoroughly. Finger stick devices at home have improved greatly. And home devices are much less painful than institutional ones. People often don't want to start testing because it hurts. So, support for home testing. Let the patient know it hurts less with the home equipment. Institutional products are made up of device and lancet built into one with no choice of penetration depth. And it's harsh. It is can hurt. So that's what the facility system ones look like. With the home product, the patient fits a lancet into the fingerstick device with a dial for depth of penetration. Now, you wouldn't be changing this dial every time. You would find out what works, but it is there. So you know what the home ones look like, different ones. And at first, it sounds like more trouble. You have to put the lancet into the device, but it's universally preferred. And there is an 800 number on the back of all meters. They have usually good customer service. People will ask about alternative site or off-finger testing. It's highly advertised. So the TV ads are misleading because it does require a blood sample from somewhere, and it may not hurt less. It could hurt the same, it could hurt more. And it is an option with most meters, not just one, and it can be less reliable in some situations. There's more variation. And I won't go into more details about that, but that, in fact, that is true. It's not generally recommended, although there are patients who it is the right thing to do. You want to demonstrate to patients that data is good. It's not numbers, good or bad. And testing is for patients to look at their numbers, adapt their behaviors when it's obvious what to do, and the potential for working together with professionals for a regimen change. So they want to know what's in it for me. So if you comment on a number in a patient's paper log or in the memory record of a meter, it's more effective to do so for an in-range or safe value and ask the patient to talk about the circumstances surrounding that kind of a number. So you want to encourage them to do more of what is working. Success breeds success. Instead of focusing mostly on what is not going well, so failure can breed failure. Just a quick statement on this. We know that generally the A1C, like below 7, most adults, and pre-meal 80 to 130, post-meal below 180. Now, we know you can improve outcomes through testing. I mean, that's been well researched. But you have to have the results in a way that they can be looked at and done something with. They have to be saved in a way, whatever that way is, that can be useful for self and professional analysis and behavior change and regimen change. So we talk about testing as a staggered way. So you wouldn't do it at the same time of day always, like only fasting. Example would be once a day before different meals on various days. This is another staggered plan. Again, not at the same time of day always. This could be twice a day before different meals or at bedtime on various days. So this is Sunday before breakfast and dinner. That's same for Monday. Tuesday before lunch and bedtime. Wednesday the same, then back to the other. It's worth considering to ask patients to do a good bit of testing on so many days before an appointment, an agreed upon plan. Another very powerful plan can be to ask the patient what they think, what's showing up, what do they believe is happening. So this could be before and one half to 2 hours after a meal, not immediately after. All right, that could be something to show you how that breakfast worked. And then it could be, say, before and after dinner. See, you're having, you can see, like, find out which medication group might target their kind of issue. And then this can be very helpful. So this is what I meant about they see something that's a problem. They can find out what walking does to their blood sugar by testing as they go out the door and when they get back. Maybe they think that babysitting the grandkids is stressful, or maybe it's relaxing, but anyway, they'll find out. Maybe before and after visiting a mother in a nursing home. So if they think something is affecting their blood sugar, they can see what is happening. perhaps running around all day on a day off to do errands, kids in the car, many things to do, they can find that out. We want to discourage what I call random testing because it will displace meaningful testing. Both will not happen. So if the person says, I test every now and then when I think about it. My daughter makes me test my sugar when she comes over to my house. I test immediately after eating a piece of cake. We want to help patients problem solve. We role model that all the time. And the patients are on their own to make hundreds of daily decisions. So point out that they problem solve every day about many things. We all do. All humans do that. Help them become skilled using the process. This is a quick review. We know we identify a problem. You consider what might help that problem go away. Pick one option, try it, see how it works. If it doesn't work, then and you can't fix that, try another strategy. Don't keep doing things that don't work. So this patient decides to test his blood sugar before and after exercise for a few days. Some common beliefs that show patient needs information, so we'll continue testing, needs more information. This is very common. Why is my blood sugar 155 before lunch when it was 140 before breakfast? And I barely ate anything. What did I do wrong? Should I not eat? You can help by saying things similar to these. There were hours between breakfast and lunch. It would not be normal for your blood sugar to be the same all the time. And it is important that you eat to continue to take in nourishment or your body will suffer. Now there is a standard somewhat less, around 15% variance in meter accuracy. It's not the same all the time with any one meter, but it is not an exact number. And this doesn't impact clinical significance. So this person says, I retested my blood sugar, my other meter. People often have another meter. Somebody loaned them one or using it of some family members. And it didn't say the same thing. How do I know which one to believe? This person says, my meter does not say the same thing as my sister's meter, the one in the clinic, or when I was in the hospital. There's a little bit of wiggle room with the numbers. Remember that 15% variance. And we are doing the right thing to go by those numbers. Finger stick testing is absolutely the best thing we have to stay in charge. It tells us exactly what to do next. All finger stick meters have this small amount of variance, even if they are in a hospital or clinic. In general, it's usually best to go with the number you get. No need to retest. That 15% variance is not clinically significant. Patient had stopped taking good care of himself. Now, this was said to me in the support group. No matter what I did, my numbers were all over the place. Tell me more, we say. Well, one morning it was 136, and another morning it was 152. So few people know of that variance, built-in variance. And that 136 and 152 are within that. And there's no reason why numbers should be exactly the same every morning. So this can be empowering information to become re-engaged, not to think the testing isn't helpful, but to understand so they'll continue to test. So here we have some help with teaching testing. Thank you.